On the other hand, OCP is an autoimmune disease where, as you can see here, what is most important is serial photographs that you need to look at for documenting progression, because that's the most important way in which you're going to establish your diagnosis. So either a very meticulous drawing or a slit lamp picture with a mandatory 3-month follow-up. And when you see the patient for the first time and you're suspecting a cicatrizing disease, you have to ask yourself whether you're facing a vision-threatening situation or not. If not, then you keep following up the patient every 3 months and look for progression, at which point in time you can subject the patient to a biopsy to know your diagnosis. And if you have a biopsy proven OCP, or if you have progression in patients with cicatricial conjunctivitis where you are strongly suspecting OCP, then immunosuppression is the treatment for patients of mucous membrane pemphigoid or OCP. And any conjunctival surgery that's done in these patients cannot be done without the cover of systemic immunosuppression now. And this has to be done along with an internist or an immunologist. And this is one of our patients who underwent fornix reconstruction and cataract surgery under systemic steroid and mycophenolate cover. And in the end stage, visual rehabilitation in these eyes is also with the help of the different types of type 2 keratoprosthesis. So it's very important to remember that especially with OCP, it is the use of systemic steroids and immunosuppression, and anything else is a strict no. Deferring or postponing initiation of appropriate immunosuppression is not the treatment in these patients, and if in doubt, always refer the patient to higher center. I will finish off with the unilateral chronic conjunctivitis variants, which is an interesting subset of chronic conjunctivitis, where the most common causes are probably dacryocystitis and canaliculitis, for which we refer the patients to the oculoplasty colleagues. But you can have, as you can see here, a tarsal foreign body which might be lodged. This is a thorn which was lodged in the upper lid, which usually leaves behind these classical scratch marks on the cornea, and you have to evert the lid to look for these embedded foreign bodies and remove it. Otherwise, the patient continues to keep having the redness. This was a patient, very interesting. He was one-eyed, where he came with this patch of redness and some whitish lesion on the cornea with a very localized area of staining here. And I really didn't know what we were dealing with, but had this doubt as to whether the patient was actually putting his finger inside the eye, especially after looking at the way the staining was taking up on the conjunctival surface. So went ahead and put a large diameter contact lens, as you can see here, and that entire redness, congestion, everything disappeared from here. But he was trying to now push his finger by pushing the lens from the temporal aspect, and developed a mild redness on the other side, which made us realize that what we were dealing with was a factitious conjunctivitis, probably Munchausen syndrome, and we also had a psychologist come into the picture to treat the patient. This was a young girl, 12 years, who was treated elsewhere for scleritis, treated with immunosuppression. Biopsy was done. She was started on anti-Cox therapy. This is how she presented, with this kind of a lesion in the inferior fornix. 1 year later, this is when she came to us. We were also unable to arrive at a diagnosis as to what this was. 1 year later, she had a similar kind of a lesion in the superinasal fornix in the right eye, and we did another biopsy, but it was inconclusive. And when we revisited her history, there was a flare-up every summer vacation. It was the right eye. It was the inferonasal quadrant to start with. She really had no complaints and always came in smiling. And then we doubted whether this was factitious, and when we got the parents and spoke to them, we realized that she had multiple issues at home, and she was trying to do this to prevent them from sending her to the hostel, which is why this kept coming back every time in the summer vacation. And we got her admitted. We did a 24-hour patch, constant surveillance for 5 days in the ward, and within 4 days or 5 days of patching, it completely resolved. Though till the end, she did not reveal to us as to how and what she was doing to cause this in the eye. But this is the same child, absolutely fine, 3 months, happy child, after 2 years of ordeal for both the surgeons as well as the family members, and we were extremely happy. Not every story has a happy ending. This was a 35-year-old female who was diagnosed as OCP elsewhere and was being treated for a year like that. And ultimately, when we saw her, these are very, very suspicious lesions. There's keratinization, there's excoriation, and this band was probably what made people think that this was a cicatricial conjunctivitis that they were dealing with. And the other eye was absolutely normal with no evidence of cicatrization. And when we did a mapping biopsy for her, this turned out to be a sebaceous gland carcinoma with a pagetoid spread, for which she ultimately required an exenteration. So to summarize, I think we need to have a very clear algorithmic approach in our heads when we see these patients of chronic conjunctivitis, revisit the history when required, keep doing repeated evaluations, take the patient into confidence. Sometimes you just have to tell the patient and the attendant that you don't know what you're dealing with, but you will, need to keep evaluating to know what the problem is. Look out for red flags specific for any of the diseases, build a rapport with the patient, and if you have any doubt, never hesitate to take a second opinion in these patients. There are a lot of other causes for red eye which can simulate what I have spoken about, but then those are entirely out of the scope of this talk, and I would like to finish this.
There's one question from Dr. Sridhanya. For molluscum contagiosum, is cryo safe over lid? And what about lid margin?
So usually
any other treatment option in children, is cryo safe and possible?
Yes, it is. It is an option, and we don't do it. We normally refer the patients to either our oculoplastic colleagues or to the dermatologist, and they do go ahead with cryotherapy for these patients.